Today we're going to take on a subject that some of you might be a bit squeamish about or maybe you don't want to deal with, but you as a counselor are going to run into these kind of problems. I'm going to be talking about sexual dysfunction, gender dysphoria, and paraphilic and other disorders. And we've sort of taken them from the book and put them all together in one particular place, sort of a general category. Another thing you're going to find out that I want you to look for as we're working on this particular thing is that this is probably the area of the most political correctness. Outside of the fact that they don't have homosexuality in DSM-5, these areas you're going to see they walk very gently, not trying to take any position of whether this is bad or wrong or anything like that. When we get into the paraphilias or that they're dysfunctional, you'll find out it's only if they feel that it's going to hurt somebody else that they see it really as a problem. And you'll just see the criteria how this is done. But as we said, DSM-5 is actually a political document also, if you think about it, what is politically correct and how the society is looking at something. And now that they've expanded up to try and bring in other societies, they're even becoming more politically correct. They don't want to say that anything is bad or anything is wrong unless it's dysfunctional or it hurts the person or the person has a problem with it. So the first category we're going to start with is the sexual dysfunctions. And you may have several of these at the same time. Just because you have one doesn't mean you don't diagnose another one, if you have each one of these areas that are going on. And some of these, you're going to look at statistics. And a lot of the other ones, we had like maybe 1%. You're going to see that some of these affect a lot of people. And so that means what? You as a counselor might end up seeing people with a lot of these different particular areas that we're talking about. Delayed ejaculation, it used to be called male orgasmic disorder in DSM-4. It's actually one of the least common complaints. But only 75% of men report that they always reach an orgasm when they have sex. Either of the following symptoms must be experienced on almost all or all occasions. And you're going to find out they use the same criteria here, and that means 75% or more situations. With partner sexual activity. In the situation, a situation, or in all contexts, and without the individual desiring the delay. First, marked delay in ejaculation. Second, marked infrequency or absence of ejaculation. And it has to go on for 6 months. Why do you think they put the 6 months in here? Because they want to make sure this is a real pattern that's going on, rather than, oh, I just had too much to drink last night, or I had a particular problem, my wife and I had a big fight, or whatever type of thing. That this is an ongoing pattern. It causes significant distress. It's not a non-sexual mental disorder, a severe relationship distress, a stressor, or substance or medication. Specifiers: lifelong, acquired, generalized, situational, mild, moderate, or severe distress. What specific treatment do we use as something like this? Psychotherapy can help. Bupropion may improve in a majority of individuals. So most of the time, what are you going to try and figure out? What's causing this? Why are they having the particular problem? And there are a number of reasons for that. And we'll get into that a little bit later, of the different things that you're going to be looking for to try and determine what the underlying factor is. But that's your job, is to ask the right questions and find out what could be causing this. Because sex is part of the autonomic nervous system. What does that mean? It should work automatically. But what happens? Our mind and other things that go on affect what's going on. So you're going to have to sort that out. The next is erectile disorder. 2% under age 40, but up to 13 to 21% age 40 to 80. At least one of the three experienced on most, that is 75% of situation, context again. Difficulty obtaining erection, difficulty maintaining the erection, marked decrease in erectile rigidity. 6 months again, clinical distress, not mental severe relationship, stressor, substance, or medication, or medical condition. Specifier is the same: lifelong, acquired, generalized, situational, mild, moderate, severe. What are you going to do and try and help this particular thing? Well, what's usually going on here? 90% of sex is in your mind. And you're programmed. It's very programmable. So certain things you think about feel very sexual. You know, what do you think the chances are that a man in this situation, if he just got fired at work and everything is going wrong in his life and the last thing in his mind is sex, and now he tries to get an erection? So there's a lot of factors, again, that you've got to sort out to try and figure this thing out. Another question would be, you need to find out if the person can maintain or have an erection in other situations. Because what's another issue? Medical things like diabetes, like drugs. There are a lot of different things can affect this particular situation. So you've got to figure that out. If they masturbated, can they get an erection? If they think about certain things, what can be done there? Of course, what's one of the treatments here? Viagra, Levitra, and Cialis. The idea for that was primarily what? For people that had medical conditions that could not get an erection, so they have the medication. But what do you think is used for today? A lot of people use it just to get turned on or use it to maintain an erection when they have other physical or other mental problems that are going on. Determine the sexual context. What's one of the main reasons here? Fear. Maybe I can't perform. Maybe I won't be able to maintain an erection. My wife will think I'm a whatever. It may be seen as dangerous, frightening, or unwanted. But another question you need to ask yourself. Okay, does this person have a sexual addiction? Are they looking at pornography? Are they masturbating? What are they doing? Do you think it might be a problem maintaining an erection if you just masturbated 5 times that day? Now, there are all these things that we get into, and again, we don't like to talk about these things, especially some of you ladies here that we're talking about all this. But if you're counseling, you have to be open to be able to really ask those questions and to be able to confront and deal with these particular issues. How have they been programmed in their thinking? Sexual programming, you're going to find in a lot of these, is the real issue. Because whatever you pair with being sexual gets paired, and if you're not using those things, you won't get turned on. A lot of people that have had sex before marriage and so on, because now that's exciting and that's dangerous and you're not supposed to do it, now when they get married, what happens? Well, it's okay. It's not so exciting. I'm not kicking off adrenaline. And it depends on how you programmed yourself to how well you're going to be able to maintain an erection and those kind of things. Now, one that's much higher, female orgasmic disorder. This is 10 to 42%. But it's not necessarily distressful. 10% of women have never had an orgasm. The presence of either of the following symptoms and experience on almost all, at 75% of occasions, of sexual activity in situations and other contexts, marked delay in, marked infrequency of, or absence of an orgasm by a female, marked reduced intensity of the orgasmic sensation, 6 months, clinically significant distress, not mental, severe relationship, stress or substance, medication or medical condition. And again, the same specifiers: lifelong, acquired, generalized, situational, mild, moderate, severe. How about treatment? What do you think the real issue here in a lot of these cases are? Well, first is going to be thinking. What's in your mind? How are you brought up? Is sex dirty? Is sex something that women should be interested in? What is your programming? And that will have a lot of effect. Another one to really take into account is the fact that for most women, without clitoral stimulation, they're not going to have an orgasm. And so if that's wrong, half of all women are never going to have an orgasm if there's no clitoral stimulation involved. So people get all these interesting ideas, especially culturally, and they can have a huge effect in this particular area of what is going on. What do you do for treatment? One of the things that they recommend is, many times, because it is sort of a squeamish area and people don't want to talk about it very much, that getting books and reading books together or learning from that particular way. Dealing with inhibitions. Understanding the partner, understanding the difference in genders, learning how to do it, but then also the whole background. If this woman has been sexually abused, some of the times they'll go the frigid direction or they'll go the actual promiscuous direction. And that's going to have a huge picture here. One particular lady that I counseled, she was brought up that if you want to have a relationship, it's all sexual. And so even as a kid, she was chasing the boys around. So she was very sexual, and she was very open to all of that kind of stuff. She had very good stimulation, very good orgasm every time, and then so on and so forth. But how many women fit that particular category? Not very many. Usually you have a situation between men and women. You get the women that come in and they say, my husband is over sex, that's all he wants. And then you get the women that come in and says, my husband never wants sex, what's wrong with me? And so these are the kind of issues you're going to get, and these are all going to integrate inside of your marriage counseling, inside of all the rest of the things that you have going on. And that's why we have to cover them, and that's why they're in DSM-5. Female sexual interest and arousal disorder. It varies with age, cultural duration. Lack of or significant reduced sexual interest or arousal as manifested by at least 3 of the following. Absence or reduced interest in sexual activities, absence, reduced sexual or erotic thoughts or fantasies, no or reduced initiation of sexual activity, and typically unreceptive to the partner's attempts to initiate. Absent reduced sexual excitement, pleasure during sexual activity in at least 75% of sexual encounters in situations and context. Absent or reduced sexual interest and arousal in response to an internal or external sexual stimulus or clues, written, verbal, or visual. Absence or reduced genital or non-genital stimulation during sexual activities. How many people do you think you might get in counseling that basically just sex isn't interesting to them? They haven't had sex in the last 3 years. You know they're married. But what effects are going to have in their marriage? Since sex is one of the methods of intimacy, of coming together, of connecting. So if you have that, you're going to find it's really a problem. Just as an interesting way that we look at this thing, the average couple should have sex about every 2.5 days. But within the bell curve, probably within once a day to once a week. If it gets outside of once a week, you're probably dealing with this or one of the other disorders, and you're going to have to determine what it is and what you're going to do about it. Another thing that we'll do sometimes with families is we'll set up boundaries. Meaning that, okay, if that's the case, with this one particular couple, what we set up was, because we found out that about every argument and every fight they ever had in their entire marriage was over sex. Because, see, he saw that he was appreciated, he'd do all these things for his wife, but if he didn't get sex, he didn't feel appreciated, and he'd start complaining and so on and so forth. So he basically said, look, it's okay. He can initiate as often as he wants to, and she can accept. If she doesn't, she gives a rain check. And if she gives enough rain checks that it's a week, he can call an emergency session. But if he blows up and gets mad and has a fight, within that week, the week starts over. So we balance the whole thing out. So you have different methods you come up with to try and make these particular things work. Another one that I use, I call the sandbox. You're going to drop our expectations, because remember, the fears underlie a lot of this stuff. So we're not going to even assume that we're going to all get an orgasm or how that's going to come out. It's just like 2 kids playing in a sandbox. Sometimes you play trucks, sometimes you play cars, sometimes you play dolls. But you get along in the sandbox, and it's okay to have fun, but we cut down on the goals. We've got an entire book that just deals with this, and what it does is really restarts the programming over again. We go all the way back to the beginning, and we learn how to touch the other person. We learn what they like, and so on and so forth, and you build up from time to time, but you have boundaries so you don't have to go so far, and it cuts down on the fears. Genital pelvic pain or penetration disorder. This used to be called dysphoric, which is vaginal pain, or vaginismus, which is the contractions. But this can be up to 15% of women that have some sort of pain. And of course, if they have pain, do they want to have sex? Absolutely not. So the deal is, how do you sort this all out? Persistent or recurrent difficulties with one or more of the following: vaginal penetration during intercourse, marked vulval, vaginal, or pelvic pain during vaginal intercourse or penetration attempts, marked fear or anxiety about vulval, vaginal, or pelvic pain in anticipation of or during or as a result of vaginal penetration, marked tensing or tightening of the pelvic floor muscles during attempted vaginal penetration. 6 months, clinically significant, not mental severe relationship, stress or substance medication or medical condition. Specifiers: lifelong, acquired, mild, moderate, severe stress. Treatment: first thing is to find out if they have a medical problem. What is it that is causing this pain, or is it a psychological thing? Relaxation techniques. Some sexual therapists actually use different levels of dilation, slowly try and get the lady to be able to dilate farther and farther so you don't have this particular problem. It's hard to help the person permanently unless you find out what the medical thing is or why is that this person is having pain. Next is male hyperactive sexual desire disorder. It used to be called male aversion disorder. And this is a fairly high numbers. It's sort of surprising here. 6% of men under age 24. It gets up to as high as 41% in men as old as 66 to 74. So these are the guys that the women comes in and say, you never want sex, he's not interested in me, and so on and so forth. Because they have an aversion or they have something why they're not that interested in sex. And how do most ladies look at that? Must mean there's something wrong with me. Why doesn't he chase me around the bed? What is going on here? Persistent or recurrent deficient or absent sexual or erotic thoughts or fantasies or desire for sexual activity. The judgment of deficiency is made by the clinician, taking into account factors that affect sexual functioning, such as age in general or psychosocial context of the individual's life. Again, 6 months, clinically significant, not mental severe relationship, stress or substance medication or medical condition. Specifiers: again, lifelong, acquired, generalized, situational, moderate, or severe distress. Usually, this aversion disorder is related to anxiety or prior experiences. So you're going to have to really look at the relationship. See, what is it? You know, is it the last 5 times he wasn't able to maintain his erection? Or she just got down and said, you're just no good. I had 5 other boyfriends that were 10 times better than you. Or, do you see what I'm saying? That's basically, it's the thing that he can't perform. He's not going to measure up, so why try? If you can't win, quit. And you get those kind of things going on. So it's expectations. And again, always be looking, though, in the back of your mind, okay? Is there something else going on? How do most women look at this? He must be having an affair. Yeah, if he's not interested in me sexually, it must not be having an affair. Of course, he could be having an affair with pornography. He could have a sexual addiction. You could have other stuff that is going on. And again, your job is to figure out what is going on, because this is not a normal condition that we're talking about here. There's something else, maybe in the past, of something that has happened. Maybe he was sexually abused growing up. And so he has a pairing there of the feelings of the abuse anytime that he's sexual. So there can be all of these kind of things that can go on. Premature ejaculation. This is one of the most usual ones that you're going to run up against. Good news, we have some good solutions. Okay? 20 to 30% of 18 to 70-year-olds have a problem with early ejaculation. Now, they changed the criteria here, and because of this criteria change, it's only going to be like 1 to 3%, because their criteria is now 1 minute. Now, if the person is sexual and they have an ejaculation within 1 minute, it meets this criteria. Let me read it to you. A persistent and recurrent pattern of ejaculation occurring during a partnered sexual activity within approximately 1 minute following vaginal penetration before the individual wishes. 6 months, clinically significant, not mental, severe relationship, stressor, substance or medical condition, lifelong, acquired, generalized, situational, mild, moderate, severe. So what can you do? What's going on here? Well, either they're doing too much stimulation, or he in his mind is so focused on this whole thing. Do you see what I'm saying? So one of the things that I teach on this is, I got a little job for you. Remember, it's mental? I tell them, count by threes. Count by twos is too easy. So count by threes. What does that do to their mind? They're not thinking about it. Do you see what I'm saying? Or maybe he doesn't need any prior stimulation. Maybe he just needs to stimulate his wife and then go for it. But the idea is it's all in the mind, and it's all in how much the person is stimulated and what they're thinking about. See, what's going on in his mind that makes him that sexually turned on even before he penetrates. Usually a situation like that, the wife will know when she's ready and that kind of thing, but you don't want to get him too turned on. But the counting by threes seems to work wonderfully for most people, because basically you're totally diverted into some other activity and you're not going to be very turned on sexually. Counting by threes doesn't stimulate many people that I know. Substance medication-induced sexual dysfunction. Here is a situation where we're now looking for those different type of medical problems. Clinically significant disturbance in sexual function is predominant in the clinical picture. Evidence from a history, physical exam, or lab findings, or both. Symptoms develop during or soon after substance intoxication or withdrawal or exposure to medications. The involved substance is capable of producing the symptoms. Not better explained by a non-substance induced sexual dysfunction, not delirium. It is clinical distressful. Specifiers: alcohol, opiate, sedative, amphetamine, cocaine, other, lifelong, acquired, generalized, situational, mild, moderate, severe distress. So what do you have to look for? The medical situation of what is causing this particular problem. What's interesting about all of this is that there are a lot of medicines out there that will do this. One of the biggest ones you're going to run into all the time is the antidepressants, the SSRIs. The majority of all of them will cut the sexual desire in like half. And you have to ask those different questions to find out, okay, what's going on, what medications are you on, and so on and so forth, because that's going to be one of the major reasons you're going to run into the sexual dysfunctions that we've talked about up till now. As an example, we'll even use it when we have someone that has a sexual addiction. We'll put them on an antidepressant, or ask them to get their doctor to put themselves on an antidepressant. And because that will go and cut down their sexual desire tremendously. Factors to be considered. You're going to have a lot of other things. Now, this is a very important list for you to get. Partner factors. Partner sexual problems or health. Relationship factors. Poor communication. Different desire levels. For the guy, it might be pretty much a functional type of thing, but for the girl, it's all about, does she feel loved, what's the relationship like, and so on and so forth. Individual vulnerability factors, poor body image, sexual or emotional abuse. Cultural or religious factors, inhibitions against pleasure, attitudes, stressors, job loss, bereavement, psychiatric problems like depression or anxiety, and medical factors including aging. So again, it's one of these things we've got to sort out all these different pieces and figure out what fits together to really be able to help this person. Now we have a category that isn't very usual. In fact, it's the least categories that you are going to see, and it's called gender dysphoria. Now, gender dysphoria is not a person that is, say, having homosexual thoughts or that kind of thing. This is a person that is a male that would like to be a female, or a female that would like to be a male. And we're going to have to break this into criteria for children and criteria for adults. Genital dysphoria in children. Going into adult, 2.2% in males, 12 to 50% in females. So it's a very broad range. 63 to 100% in males after they identify this way, identify as gay. So there's a very strong connection of people struggling with this, of eventually getting into the gay lifestyle and into homosexuality, into those kind of things. 32 to 50% later identify as lesbians. So you get the same idea of what's going on here. But in this case, listen to the criteria. A marked incongruence between one's experience and expressed gender and assigned gender. Now, the way they use the terms is, assigned gender means that's what your anatomy is, okay? Or at least 6 months duration and manifested by at least 6 of the following. So that's quite a number here we're looking at. A strong desire to be of the other gender, or insistence that one is of the other gender. For boys, assigned gender. A strong preference for cross-dressing or simulating female attire, or in a girl's assigned gender, a strong preference for wearing only typical masculine clothing and a strong resistance to the wearing of typical female clothing. Now notice we have to have 6 of these. So if you're worried, well, maybe I was a tomboy, the idea is tomboys are not going to qualify for 6 of these different criteria that we're looking at here. It has to be much stronger than that. A strong preference for cross-gender roles in make-believe play or fantasy play. A strong preference for toys, games, and activities stereotypically used or engaged in by the other gender. A strong preference for playmates of the other gender. In boys assigned gender, a strong rejection of typical masculine toys, games, and activities, and a strong avoidance of rough and tumble play. Or girls assigned gender, a strong rejection of typically female games and activities. A strong dislike of one's sexual anatomy, a strong desire for the primary or sexual sex characteristics that do not match one's gender. Clinically significant distress or impairment. Specify with a disorder of sexual development, that's hormones. Treatment, the earlier the better. What is the function or the reason for the change? What is the reprogramming? See, again, if you're brought up in a certain way to believe certain things, you're going to want certain things, right? How do we develop an identity? You decide you want something and you focus on that particular thing. So as young kids, this is a gender identity thing, and that's why the numbers are so high. Initially, that kids are, well, maybe I think I like mommy better than I like daddy, so I think I'm just going to be a girl. Well, with kids, that's not too big of a deal. Now let's look at adults. Gender dysphoria in adolescents or adults, extremely rare. 0.005 to 0.0014 in males, 0.002 to 0.003 in females. So you're not going to see very much of this at all, especially after the kids are sort of grown up. And it's basically the same criteria that we had for the kids, except it won't be as much playing with the toys and so on and so forth. I guess we will look at it here. A marked incongruence between one's experience and expressed gender and assigned gender, or at least 6 months duration, manifested by at least 2 of the following. Notice there's only 2 here. It was 6 before this as a kid. Okay? A marked incongruence between one's experience and expressed gender or assigned gender and or a secondary sexual characteristics in adolescence and anticipated sexual characteristics. A strong desire to be rid of one's primary and or secondary sexual characteristics because of a marked incongruence with one's experience or expressed gender. A strong desire for the primary or secondary sex characteristics of the other gender. A strong desire to be of the other gender or some alternative gender. Notice that they put that in there. What's that saying? Some people, as an example, gay is what? An alternative gender. because there is no such thing as a gay person, do you understand? We only have male and female in assigned gender. A strong desire to be treated as the other gender. A strong conviction that one has the typical feelings and reactions of the other gender. Clinically significant distress or impairment. Specifiers with a disorder of sexual development, that's hormones. In-depth evaluation required. Barriers to relationship intimacy are profound. When you get this thing all confusing, how many problems do you think you're going to have? Huge. And the idea is to sort that out and do what you can. Sexual reprogramming, group therapy, helping them to accept themselves, those kind of things. Unspecified gender dysphoria. Again, so we have things that don't really fit that can fit into there. Our last category today is paraphilic disorders. One of the interesting things that they note in here is it could be an OCD spectrum disorder. I mean, you could have these kind of things because they're so focused on particular interesting areas. I don't look at it that way. I look at most of these are all based on sexual programming. That there's certain things, and what does that mean? It means we're going to have to figure out some way to understand what it is, what's the payoff that they're getting from these particular things and doing these particular activities. But here's one of the critical things. Now they break these into 3 categories: courtship disorders, pain disorders, and target disorders. They must cause distress or impairment, personal harm, risk of personal harm to others to be a disorder. So the way they're looking at this, just because you have some kinky ideas or kinky sexual programming, or you want, the only thing you're interested in is women's panties. We actually had a guy one time that came to treatment, and he had actually been part of a gang that were raping women, but he didn't want to do that, he just wanted their panties. So do you see, it's programming. There's something interesting here of what is going on here with this particular person. Treatment modes: evaluation only, psychotherapy, medications, external control. You have to do whatever you can do to try and get these things under control. And of course, this is also an area where SSRIs, Provera has been used. Female hormone has helped for these things also. First one is voyeuristic disorder. Up to 12% of males and 3% of females lifelong. Over a period of at least 6 months, reoccurrent or intense sexual arousal from observing an unsuspecting person who is naked in the process of disrobing or engaging in sexual activity, and manifested by fantasies, urges, or behaviors. The individual has acted on these sexual urges. See, notice there, you wouldn't give this if the person hasn't acted on it, they just have these feelings or have these thoughts. But you have to think about it. What are the chances are they might act on them? With a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, and other important areas of functioning. At least 18 years of age. So you don't do this with kids. Specifiers: in a controlled environment and in full remission. Why are they going to have in controlled environment in all of these? A lot of these people are in jail. And in jail, you're not going to meet this criteria, are you? But they can still have the thoughts there. They might not be able to act them out. So what kind of things are we talking about here? Well, it actually, technically, watching pornography could fit this, couldn't they? But it's not real people. Normally it's applied to people watching through windows or putting hidden cameras places or doing that kind of stuff. But in pornography on the internet, how many things do they set up for you if you're a voyeur? So you see the kind of things here. The next one is exhibitionistic disorder. Up to 2 to 4%. Over a period of at least 6 months, reoccurring or intense sexual arousal from the exposure of one's genitals to an unsuspecting person as manifested by fantasies, urges, or behaviors. Notice the unsuspecting is always in here, or the unconsenting person. Individual has acted on these urges with a non-consenting person or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important activities. Specifiers: sexual arousal by exposing genitals to children, physically mature individuals, both, or in a controlled environment in full remission. So what's the reason here? The suggestion is one of two. Either it's for shock type of thing, or it's for sexual acceptance. They also say here, which is very interesting, that you wouldn't give this criteria if it's part of homosexual courting. They're saying homosexuals many times will do that, and that's an invitation type of thing, and they wouldn't see that as fitting this disorder if that was the case. Fraternistic disorder, up to 30%. So some of these things are the interesting statistics they give here. You say, okay, don't think I've had many of those in treatment. Over a period of 6 months, recurrent or intense sexual arousal or touching or rubbing against an unsuspecting person as manifested by fantasies, urges, or behaviors. This is like you're in an elevator and you're pretty close to somebody. Well, maybe you don't know what's going on, but they get turned on basically by rubbing on somebody else in a close environment like that. The individual had acted on these sexual urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas. The same specifiers. It is a criminal act. Sometimes they say it might be a light form of sadism. And we'll get into those here in a little bit. The next one, sexual masochism disorder. They only had statistics here for Australia, which was interesting. 2.2% of males, 1.3% of females. Over a period of at least 6 months, recurrent intense sexual arousal from the act of being humiliated, beaten, bound, or otherwise made to suffer as manifested by fantasies, urges, or behaviors. The fantasies, sexual urges, and behaviors cause clinically significant distress or impairment. Specifiers. One is very interesting. Here is with asphyxiation. That sometimes this is a deal where they will try to, they'll be hanging themselves or something like that to get a higher sexual urge. Restricted breathing in a controlled environment in full remission. So these kind of things, how would you think this could come about? That the person has been paired sexually with being abused. And so to them, they've been reprogrammed or programmed that you get a sexual high if you're in fear. And so fear has somehow gotten programmed and attached to the sexual feelings. And again, what does it kick off? Adrenaline. Just like in sexual addiction. If you're afraid you're going to get caught, you kick off adrenaline as well as the endorphin. Here again, the feeling that you're going to get, you're being beaten or other things are going on that ties in with previous things. So if I was treating this, I'd be looking at, okay, what happened to this person before? What abuse had they had? What kind of things are going on to sort out why they got programmed this way? And again, what are we going to want to try and do? Reprogram. Sexual sadism disorder. They say between 2 and 30% might meet this criteria. Over a period of 6 months, recurrent intense sexual arousal from the physical or psychological suffering of another person as manifested by fantasies, urges, and behaviors. Acted on urges with a non-consenting person, or the fantasies, sexual urges, or behaviors cause clinically significant distress or impairment. Again, specifiers in controlled environment and full remission. What's interesting they say here is only a minority of rapists meet this criteria. It's unresponsive to ordinary psychotherapy. Why is this dangerous? These are the people that might get carried away and kill somebody, or they're abusers. And so you can see that people have those thoughts. I'm going to be very concerned, even if they say they haven't acted out on them at this particular point. And we're going to find out there's a lot of denial in the categories that we're looking at here. Probably the biggest one that you're ever going to deal with is paraphilic disorder. 3 to 5%. Over a period of at least 6 months, recurrent and intense sexual arousing fantasies, sexual urges, or behaviors involving sexual activity with a child or children, generally age 13 or younger, acted on the urges or fantasies or sexual urges or behaviors cause clinically significant distress or impairment, individual age of at least 16 or at least 5 years older than the child or the children in the criterion A. Specifiers: exclusive type, that's only children; non-exclusive type, sexually attracted to males, to females, and to both. And they're sort of grouped by targets. Let me give you a bit of background here, because this is a huge area you have to be very careful with if you're going to deal with it at all. They have what's called fixated pedophiles, and those are the ones that, due to something has happened to them, it's like they stop growing. They still see themselves as a 7-year-old kid when they were abused. And because of that, they only target kids of that particular age. And so they're fixated on a particular target. And there's regressed. Regressed is not as difficult to deal with, because those are just people that are so sexually, they're looking for sex with anyone or anything they can get their hands on, that kind of thing. Denial is absolutely huge, beyond imagination. One particular study, I went to a seminar, and this lady had gone in and interviewed all these sexual addicts that were in prison, all these pedophiles. And one of the things they did, because in these particular cases, if you're doing treatment with pedophiles, you need to use a lie detector, or you need to use another system that will measure the erection of the person as they look at things to determine what they're really thinking. Now, why is this the case? Because the denial is the strongest in this area of anything. This particular area, they took a large number of pedophiles, and they had been arrested and so on. They asked them, okay, how many children did you act out with? And they were told, well, you know, 1 or 2 or those kind of things. And then they said, now, in order for you to get into this sexual addiction treatment program for pedophiles, you have to pass a lie detector test. And that's how they use a lie detector test. Then the average pedophile admitted an average of, I think it was 283 children that they had acted out with. I mean, it's just absolutely, you can't trust anything that they're saying. You can't accept anything. If you pick up, say you're talking about sexual fantasies, something that we'll do, because if the person has sexual fantasies about kids, what do you know? We possibly have a pedophile here, even if they haven't acted out, because they're not going to be telling you. And so this is a whole area. What's another area? Physically. See, many times they're ordered to stay away from children. If you're going to treat somebody in a church environment like this one, what are you going to have to do? Have them escorted 24/7, at a minimum, even if they have some recovery. So this is a huge area of treatment, and a very difficult area of treatment. Fetishistic disorder. Over a period of 6 months, recurrent or intense sexual arousal from either the use of non-living objects or a highly specific focus of non-genital body parts, as manifested by fantasies, urges, or behaviors. Fantasies or sexual urges that cause clinically significant distress or impairment in social, occupational, or other areas. The fetish objects are not limited to articles of clothing used in cross-dressing or devices specifically designed for the purpose of tactile genital stimulation, like a vibrator or something like that. Specifiers: body parts, non-living objects, other, in controlled environment, and full remission. If the garments are used for cross-dressing, they can receive this particular diagnosis. One thing that was interesting is, when we went back there in gender dysphoric disorder, is that it was talking about all sorts of cross-dressing for the kids, but when we got to the adult version of that, it didn't mention that at all. So this would probably be the appropriate diagnosis for someone that is cross-dressing, would be seeing it as a fetish instead of something else like that. How about other mental disorders? Many other things here, other specific mental disorders due to another medical condition. Unspecified mental disorder, other specified mental disorders, unspecified mental disorder. Medication-induced movement disorders. This is a whole nother area, primarily with people that are using the neuroleptic drugs. Here's neuroleptic-induced Parkinson's, malignant syndrome, all these different things that the medicine does. So we have categories for all of those. And then finally what we have here is a whole other category called other conditions that may be the focus of clinical attention. These are what were called the V codes, and there's still V codes in DSM-5, but they've increased this hugely. It used to be a short list, now it's a very long list. But the first is psychological factor affecting a mental condition, a neurological induced problem, and then these V codes. And if we go through an entire list here, I'm just going to read some of them, but the list has 87 V codes. Now, how do you use these V codes? It helps you describe what's really going on with this person, because what kind of things have we not seen up till now? We haven't seen anything about abuse, have we? Let me just give you an idea of some of the V codes that we're talking about here. Parental-child relationship problem, sibling relationship problem, upbringing away from parents, child affected by parental relationship distress with spouse or intimate partner, disruption of family due to separation or divorce, highly expressed emotional level within the family, uncomplicated bereavement. Then we have child physical abuse, encounter with mental health services for a victim of child abuse by parent or non-parent, personal history of physical abuse in childhood, encounter with medical health by perpetrator of parental or non-parent child abuse. And then it goes, it takes those four, and then it does the same thing for sexual abuse, does the same thing for child neglect, does the same thing for psychological abuse, does the same thing for spouse or partner violence, and then we have that sexual or physical again. Then we have partner neglect, we have abuse psychological, we have physical abuse, other circumstances related to adult abuse, and then we get into a lot of other ones like homelessness, inadequate housing, discord of neighbor lodger or landlord. I'm just jumping down through some. Extreme poverty, low income, phase of life problem, victim of crime, conviction of civil or criminal proceeding without imprisonment or other incarceration, sexual counseling, religious or spiritual problems. So it covers about everything. So what are you going to do with all of these V codes? You're going to use them so when you have your criteria, you have your diagnosis, you're going to add the V codes that are going to explain what's really going on in this person's life. And you're going to sort that all out. And of course, these apply to all of the diagnoses that we've had up until now. So what have we done? So far, we have covered basically all of the diagnoses in DSM-5. And we've given you a general overview, realize a very fast overview of all of these kind of things. Next time, we're going to tell you what are the steps of doing diagnosis, and we're actually going to practice some diagnosis next time when we meet. Let's pray. Lord God, we call upon you that you would give us wisdom. This can be totally overwhelming, Lord, of all this information, especially for people here that have never heard any of this before. But Lord, we know that you can guide us, you can give us wisdom, you can help us, Lord, that we could use this effectively in helping people in Jesus' name. Amen.